real problem that we have globally, but particularly here in South Africa with infections of young women. Globally, there are about 390,000 new infections among young women in the world, about 1,000 per day, a completely unacceptable statistic. And so just for a minute or two, I just want to bring to your attention a couple of studies among many that are trying to address using a pre-exposure prophylaxis approach of a dapivirine vaginal ring. Some of you may be aware of the ASPIRE study, which was completed and showed some interesting, in some cases encouraging, in some cases discouraging, but all being provocative results. That if you look at the entire study, about 27% efficacy, up to maybe 37%, but when you broke it down into age group, if you were a young woman less than 25, particularly if you were closer to 20, the results of that study showed almost no efficacy. If you were older than 25, it was considerably higher, well over 30 to 40%. However, we've done now a subgroup analysis of the study and showing that if you rely on people having taken the procedure of inserting and using the dapivirine ring, the efficacy could be as high as 50 plus and even as high as 75%. So because of that, we're trying to figure out what the reason for that is vis-a-vis adherence. And so today, actually, we launched the HOPE study. And what the HOPE study is going to do is they're going to replicate the design of the ASPIRE study, except make it so that a person does not come into the study only because they want to have the advantage of the services, because those may be some of the ones that you get fooled into thinking that they took the intervention and they didn't. So it's an open label study that has individuals come in, even if they don't want to participate in the actual study themselves, they just want to avail themselves of the services, which takes away all of the confounding incentives and disincentives for a study. So we're really excited about that we've launched that study. One other thing that's important is the now data that's out on the study, where it's very clear now that treatment of women, pregnant women, intrapartum, peripartum, and postpartum can essentially eliminate breastfeeding related transmission of HIV. So we have some important science, and as I've said when Deb and I were talking at the opening of the PEPFAR meeting, we follow the science, and that takes us to where we need to implement. And right now, the science is quite solid that we will be able to prevent HIV infection in women. And one last thing I just want to bring to your attention, there is a study called a REPRIEVE study, which is looking at trying to decrease cardiovascular disease in individuals who are treated with HIV infection by making available to them statins to decrease the incidence of cardiovascular disease. Women now are coming into that cohort. We need to continue to bring women into that cohort. It's a 6,500 person study. We've only recruited about 1,600 people, so we want to encourage individuals to enroll in that study, which we think will be very important. I'll stop there and hand it over to Deb, and we'd be happy to answer any questions. Deb?
I'll introduce Ambassador Ferguson, person who leads the PEPFAR program, very important in this part of the world, has been extraordinarily important to date. A huge emphasis on treatment, Ambassador Ferguson, today, clearly making sure those numbers come up to scratch, but increasingly turning its attention to say how can we stop the infection. And so that's the question. How do we implement this?
Great, thank you. It's really a privilege to be here with the both of you, because I want to start by making a very important comment. Over the last 5 years, both the South African scientists and NIH in their research that they have been doing have been sharing information with us early before you see it packaged in abstracts and posters and in presentations. And it was on the basis of their information and the basis of the incidence of high rates of infections in young women that we really put together the DREAMS program. based on the information very much coming from NIH-supported studies here in South Africa, where they really define, and you'll see more about this presentation tomorrow, but really defining what girls are at the most risk, why are they at risk, who are they having sex with, and how do we change the future for young women. About 6 years ago, Secretary Kerry and Secretary Clinton at the time launched what we call the Violence Against Children initiatives. And they were surveys that we put into the field. We started out doing 1 or 2, we've now done 11, and 17 are planned total within the next 12 to 24 months. These surveys showed us that in addition to the high incidence that we were seeing, that the level of gender-based violence, where 25% of young women to 35% of young women's first sex is sexual assault and rape. We went on to ask those young women about what about their sexual violence history, their lifetime experience. These are 24-year-old women. Their lifetime sexual violence experience approached 50% across every country we have studied, whether it's Haiti or Zimbabwe or Zambia. So DREAMS, determined, resilient, empowered, needs-free, mentored, and saved young women, please come to the DREAMS booth and please have a dialogue with young women to really understand what's putting them at risk. But DREAMS is really about creating a different future for young women. Working across in a multi-sectorial approach, again, coming from information and studies out of Southern Africa, really showing that education, retention in education is absolutely critical, decreasing incidence or prevalence of HIV by more than 30% for women. So I'm taking together that data, the gender-based violence data, the need to really change the brand of young women in the community. We joined with Bill and Melinda Gates Foundation, Girl Effects, Eve Healthcare, Johnson & Johnson, and Gilead to work together using the best scientific evidence and the community relationships and young girls' voices, not only seeing them and hearing them, but bringing them in as part of the solution and how we're approaching that, and putting that together in a $385 million package. When we looked at it there, we felt like there was still community efforts that were missing. And so this week we're announcing the winners of the $85 million proposal, of which 50% have never received PEPFAR dollars before. We've put out $70 billion, $70 billion US government dollars in the last 13 years. 55 billion of that in the last 8 years under President Obama. So it's difficult to find people who have not received PEPFAR funds, but we found local groups, small grassroots groups, youth-led often, to really engage with us in finding an innovative new solution, because we have to be honest, we've only decreased incidence by 15% in young women. So we have to know we've done some things right, but we have a lot more to go. I'll end with just one. We are so always thrilled by the work that NIH does. We took PROMISE and its insights, and we're putting another $15 million to continue to follow those mother-baby pairs, to really find out what keeps women on treatment, because we've launched into B+. And so PROMISE has become PROMOTE, and we really want to show that we're investing in both implementation science and the implementation to really understand how to do programs better. Finally, I don't want you to think we've left young men behind. So we've been working very closely with young men based on the CAPRISA data to increase voluntary medical male circumcision. We've done over 10 million circumcisions in the last few years. And we're also looking at the other end of the spectrum, 25 to 35-year-old men, the least likely to test for HIV, and so none of them know their status. We're working with the 25 to 35-year-old men to find them, get them tested, and immediately link them to ART. And we believe that combination, prevention, multi-sectorial, all-embracing approach for young women in the community, treatment, circumcision, condoms, together, prevention and treatment linked, not dislinked, not creating artificial separations, bringing them together for maximum impact. But what I'm truly excited about is the sharing between scientists and implementers so that we can translate new information immediately into better quality programming.
Thank you very much to both of you. Let me say that this is really urgent. So from where I sit, and I'm in Cape Town, not in KwaZulu-Natal. And I think there's a notion that this is where all the infection, occurs. But actually, Sub-Saharan Africa, and certainly the east and southern region, is indescribably hit. So, even in my city in Cape Town, I see young women incidences of 8 out of every 10 every year becoming infected with HIV. And our choices have just not been sufficient to date. Or perhaps we just haven't put those choices together in ways that have had impact. And so what I hear is, on the one hand, more choices being put into our hands, and I'm very excited about calling it the prevention revolution. There are ideas coming through that we have to get into the field as soon as possible. And then we're actually being shown how to do this to the best effect for the greatest impact. And I'm looking forward to seeing this, bench to feel back to us to say, how do we hone this to get this right so that we can really turn those statistics around. I think it's also really important to know that once a young person becomes infected, on the one hand, they have a lifetime to transmit to unborn children and to partners, so clearly that would be what we prevent. But also, it changes the fabric of society and how we really sort of drive our society. So really critical that we begin to see those numbers go down, because this is the one population in which UNAIDS tells us we continue to see mortality rates rise. And so we have to do something about this sooner rather than later. So we will now open to the room if there are any other questions anybody wants to raise in particular. Happy to answer.
My name is Lucy Bradley Springer. I'm the editor of the Journal of the Association of Nurses in AIDS Care. And I'm convinced that when the women's epidemic is related to violence, which is related to cultural issues of putting women in a second-class position and not paying attention to their rights. And I'm wondering what's going on in that area.
Great, I'll be real brief because I tried to touch on this just a little bit. In the beginning of the President Obama's administration and Secretary Clinton, she had a deep concern about gender-based violence and saw it in every place where she went. And that was why the Violence Against Children surveys were launched. And because of those surveys, legal frameworks have changed. But there's a vast divide between the changing of legal frameworks and changing of the community to ensure that gender-based violence is no longer normative. So yes, we're working with men's programs, and yes, we're working in the community under DREAMS, but there needs to be a complete normative cultural change, as you just described, for all women in order for us to have a different outcome. When I tell you a third of the young girls experience first sexual experience is rape, that means their mother or their aunts or their grandmothers have had that same experience. There's a level of acceptance that is a normative experience for young women. That's what we have to change, or we're not going to get perpetrators prosecuted. We're not going to change this. Part of DREAMS is bringing in the private sector to help us with that branding change, where communities will want to be branded as a gender equality, violent, anti-violence community, and where the brand of a young woman is applauded and valued. And I couldn't agree with you more, and it's these kind of normative changes that we have to see in a leapfrog way, just like what's happening in telecom. I believe it's possible, but we have to work it.
Also, I think it's important to call out leaders, community leaders, and leaders of countries to articulate very clearly and unequivocally how unacceptable this is, because as Deb said, if you sort of say it's part of life in a particular area, that is as wrong and evil as doing it yourself. So accepting this as part of a societal issue, as far as we can see, at least in the scientific community, is something that is unacceptable, needs to be aggressively spoken out against. Otherwise, society is not going to spontaneously change by itself. It needs leadership.
And I would just add that, this is where the R&D has been so important. We have needed to give young women something they could use discreetly. Whilst we fix society, which, there's no doubt that needs to happen. But in the meantime, my job is to protect those young women in whatever way I can. And, so we have needed prevention tools that do not depend on their partners. And today, that is all I've had to offer a 17-year-old is, can you ask your intimate partner to use a male condom? And even if she managed to get her hand on a female condom, she's not going to be able to do that discreetly. And that has generated some of that gender-based violence and that element of non-control. I'm running a PrEP study myself with young women in Cape Town, and I would quote a 17-year-old who said to me, for the first time in my life, I own my own sexuality. And that kind of agency is what we really want to multiply across the continent and more. And so, we have to continue to look for other options that really will enable young women to take control of their own lives, whilst we work on these much bigger issues, which there is no doubt needs to be done. So thank you for raising it. Are there any other? Yes.
Thank you very much. My name is Adam Nti, and I wear a lot of hats, including the fact that I'm an HIV/AIDS advocate for young women, but I'm also a media person covering for the Zimbabwe Broadcasting Corporation in this conference. Thank you so much, Ambassador and Anthony and Linda, for what you have said. But I want to zone in on PrEP that you talked about, Linda, which is what science is telling us, that PrEP works and PrEP should be there right now, and that's why the WHO has been setting up guidelines. But I want to hear more about PrEP within DREAMS. What is the plan and how do we get PrEP, especially in countries such as where I come from in Zimbabwe, where PrEP is not particularly something that is available?
Great question. So 5 countries in the first round of implementation are already starting PrEP for young women. So that's really important for us to really demonstrate that feasibility, because you just heard about this question of ability to adhere. And we believe young women will adhere when they know they're taking something effective. So we have launched in 5 countries PrEP. There's a whole series of new PrEP work that will come into this 85 million. So thank you for that question. It is part of our implementation of DREAMS.
And we will hear more during this conference, and I think in the next probably few months as these demonstrations and other demonstration projects start to come to fruition. I think, it's not enough of work, but how do we implement it? And I think this is where DREAMS and other programs are going to be so important for us to answer. Any other questions?
French Light with RGB. Can you describe briefly, very simply, your input, community input experience? The community input, how do you organize that?
Well, I'll start really quickly because this has been a big emphasis over the last 2 years. So we have opened up all of our processes to the community, to it. Not only our data, which is completely transparent now, it's on our website down at the district level. You can see our performance in every single district across every budget code. I know that doesn't sound like much, but it's a lot. It's over 50,000 sites within districts, and within that, we've also opened up what we call our country operational plans, discussions, and reviews, to the point that in this last set of reviews, which was amazing, we had community, government, our multi-sectoral partners with WHO, UNAIDS, and Global Fund, all together to help us create the best program we can in each of the 60 countries that we work in. And so, now, routine community engagement occurs 2 different ways. One of them is routine working with the risk group that we're specifically focused on, whether it's key populations, sex workers, sex with men, gay, bisexual men, trans women, prisoners of
struck by the very clear and open presence of community involved. In fact, the first thing I did when I walked into the clinic was be introduced to the community leader, the CAB leader, and very much involved in the study, and the participants in the study related their relationship with the community as one of the important reasons why they were involved in the study. It was really quite starting. I didn't expect to see that very creative.
So I'm part of the NIH Food and Environment in this country, and this makes such an important role to me in terms of the research we do. And it is a requirement that we not only, on paper show that we have community engagement, that it actually is actively happening. And I believe that every clinical trial scientist linked to many of the studies we've heard described here had the very cool part of the work is community engagement. Community is involved right from the point of protocol extension and protocol design all the way through to results dissemination and finally actually the products into the field. So I'm happy to discuss that in more detail as well. I'm very proud of it, and so I think made this significant contribution and this week to that really grateful to the National Institute providing
Yeah, let me just apologize. The reason we started a little late is because I was over in March. So that's why we're not over because I think it's not just a matter of words, it's actual physical engagement and direct funding. And really putting our words into action and really showing that we trust community-led programming and services and to really honor that.
Hi, my name is Catherine. I'm from the Times Institute of South Africa. Clarity for our works. You said you're starting to work in 5 countries, so that is South Africa and Iran. And then you said that there was violence, but I thought you were going to experience sexual violence. Does that also include South Africa in that study?
So that study has not been done in South Africa. It's been done in a lot of other countries, but in countries certainly that are in South Africa. We have not found a country yet anywhere in Africa or Haiti where the violence is less than 23% as first sex, being sexual assault, and nothing less than about 39% for lifetime experience of 24-year-olds with sexual violence. And I think we just have to remember this is a common phenomenon where I think it's also been raised in the United States by President Obama and the First Lady that 1 in 5 young women in their 4 years experience at college in the United States are being sexually assaulted. So this is a shared problem globally where it needs to be addressed. It started in South Africa as part of a sex worker program. It is not across the board in adolescents. It's hard to reach yet, but we do have countries that are doing that.
Perhaps I can just add that, when we introduced Monica, I had a research that found very similar analysis. So that certainly violence is right, globally, I think. But at the end of the day, the government is seriously thinking young women and skills that the safety program is one of those unfortunately. We feel more right as far as this Well, I think that has been really great to hear from the two very important players, and we are hopeful that we will get to see those numbers begin to turn down in the next five years. And I look forward to the rest of the conference. We'll see more of that detail. I know we'll be watching again tomorrow afternoon. There will be some excellent data presented and throughout the conference. I look forward to seeing that and the rollout of some of the innovation in the youth programs and other programs that are about to come. I think one of you are available if there are specific interviews or questions that might want to be raised personally. Otherwise,